Good evening, everybody. I am Dr. Sanjay. I am the Clinical Director of Peerless Hospital, Kolkata, Pediatric Department. And it's indeed a great pleasure today to invite on board Dr. Sanjay Pandey, who is the head of Urology and Andrology at Kokilaben Ambani Hospital, Mumbai. A man of many parts, and he has a wide range of interests. So his urology skills range from pediatrics to geriatrics, as he tells me, and his specialty is gender reassignment surgery as well. But today we have on board Dr. Pandey to discuss pediatric urological problems, so that we get a better grip on this. And as a pediatrician, I often find children with urological problems who I need to counsel and make a plan for, and there I often get stuck. And he has been kind enough to help me out with these problems in the past. So it was a brainchild of his as well as mine that we have a platform where we can discuss these problems together. So I would invite Dr. Pandey to say a few words before we start off with the cases and the discussion for this evening.
Good evening, Dr. Sanjukta Day. Good evening, everybody in this august audience. I have also a few of my colleagues who have joined in today to have a supporting network that we can create. Thank you, Sipla, and the entire team behind this. The brainchild has been a 50-50 with having seen Dr. Sanjukta's presentations in recent months, and obviously in recent years since we have known each other in pediatric format. I think it behoves very well that this is a great kind of opportunity to interact. Pediatricians and pediatric patients don't only live in Kolkata and Bombay, but in smaller 2-tier and 3-tier cities where many of our colleagues do practice pediatrics, pediatric surgery, urology, and reconstructive urology. I think it behoves well that we take this subject to highest possible levels over an interaction that you have planned. I'm sure you don't have many bouncers for me, but I've just come down from the operating room and I'm happy to be a part of this wonderful plan that you did on a Thursday evening. So Dr. Sanjukta, we can go ahead the way you plan it. I was told it'll be wonderfully interactive, and later on you can take questions too, is what your plan is. So kindly go ahead. I'm sitting in my office in the Kokilaben Ambani Hospital, the second floor, a department of urology. And like all urologists and all colleagues who do practice pediatric and geriatric, we do work on reconstruction, robotics, and functional urology. And here we are attempting to handhold many of our colleagues as a team between Dr. Sanjukta and myself on the kind of practices we do, and maybe attempting to bust some myths, maybe look at some strong statements, some capabilities, and just polish ourselves and go back tomorrow again, recharge to the outpatient department. Thank you. Thank you for inviting.
So I will start off today. It's a just a minute. I'm just trying to screen share here.
Sure. While you do that, and while you get back to your first slide, friends, pediatric urology is a different ballgame because many of things which happen in the pediatric age group can be corrected then and there, number one. Number two, many a times parents take in the stride and look at this could be a part and parcel of healing processes, and possibly in due course of time, they would come back a little late. Child always does not complain. And therefore, the challenges for pediatricians and pediatric surgeons across the country and the world has always been to pick up things a lot from whatever is discussion, or so much from examination, and so much from very focused investigations. So Dr. Sanjukta, we are ready.
Yes. You remember, Dr. Pandey, that we met in Mumbai in a bedwetting conclave, and I was pleasantly surprised to see a urologist there doing something lowly as a bedwetting clinic, because that's something that's considered a niche area and not something that surgeons will like to do. So I will go through some cases and then I will ask you for your opinion on these. We run a bedwetting clinic, and often we see children like this one, a 14-year-old female, and she has been bedwetting forever. Her sister also wets the bed. The parents and siblings think it's natural to do so. She often drops school because she's so tired in the morning that she cannot get up and get ready to go to school. And they are kind of in the situation where they just want it to resolve on its own. And they see the pediatrician for cough and cold, but they have never really mentioned this problem because they didn't think it to be the problem. Similar to this is an 11-year-old male who has urgency, diurnal urgency, occasional incontinence, and nocturnal enuresis approximately 3 times a week to up to 5 times a week. So nearly every day. And that really affects his schoolwork. And he's scared to go to school because often because of the incontinence and the diurnal urgency, he's stopped from going to the toilet when he goes to school. He's scared to go to school. There are some benefits with medicines during the daytime, but the nighttime enuresis hasn't stopped at all. And there is case 1C, where there is a 15-year-old male who is incontinent, who is stable. He wears diapers. He's wet at night, so he wears diapers all the time, and he never went to school. So I would ask Dr. Pandey to go back to the cases and give his opinion about how he would manage these one by one.
Wonderful. So this actually takes us from the left of A to the right of Z. It talks about children with bedwetting and incontinence, and we understand the wet child is sadly a demoralized child who's getting always booted at school and with parents around. So let's look at this girl, 14 years. Parents did wait for that time because the 4th sentence is they think it's natural. She also dropped school out of this care about being wet at night, and also there were issues that she was always worried about it. So there was it playing in her mind. She's no more a young girl. She's grown adolescent and she's now grown up girl. She understands it. So this is where we look at the society and we look at all these issues which are quality of life issues sometimes are forgotten in the very busy schedule of parents and children and siblings around where people bedwet. Bedwetting is something which can be looked at as a pathology, as a disease process, as a phenomena. I would name anything from 6 years onwards. That means that there's a brain and a bladder rhythm being developed around, and children do develop this rhythm as a part of toilet training, which happens in day and night too. But this can actually affect children at age groups of that. Beyond 6 to 15 years, that age group are those groups which actually go to mind and body changes, where if the parents have not taken up that charge, these cases could resolve in a small subset of patients, not in everybody. It will be sad if they carry on to adolescence and beyond to adulthood, where sometimes the management would be quite difficult. So we saw somebody who bedwets at night, somebody who bedwets day and night, and somebody who's on diapers all the time. So looking at the first child, 14 years is quite some time. We waited too long, waited for natural things to happen, which may not happen to her, and a sibling who actually bedwets twice. Let's get understanding that while enurescence of bedwetting, which is celebrated once a year as an awareness drive, which happened on 26th of May 2020, and every year on the last week of May, there's a day designated towards awareness for parents and fraternity. It is important to understand just few quick things. Number one is to know what are the eating and drinking habits, because a lot of the treatment will happen from the doctor across the table, and so much will happen on the behavioral therapy, which will be initially inculcated by the parents, later on by adolescent children. If the children are between 6 to 9 and 6 to 10 years, difficult to motivate them alone. But that's where we need to motivate the parents. But when it comes to 11 to 14 years patients, like the one you have, here, the case 1B, which you have projected, is diurnal urgency and occasional urge incontinence in daytime, which means this is a non-monosymptomatic enuresis. He has got nocturnal enuresis 3 times a week, some benefits on medicines which have been attempted in the past, and he's scared to go to school because he also has got diurnal urgency, urge incontinence. Let's take this child to start with. So he has got daytime symptoms and nighttime symptoms. Not a very uncommon phenomenon. Believe me, many of these patients who were actually thought of in yester decades as monosymptomatic have actually on deep discussion, evaluation, and warding diary given us a picture that their daytimes are also uncomfortable. So when you meet across such patients, obviously the parents and the caregivers, you do talk to them. So out here, it's too much of talking. Therefore, these niche areas are handled by urologists too, Dr. Sanjukta. And as you rightly said, we have opened up a nocturia and bedwetting clinic 3 years ago. So we run a successful 6 days a week nocturia and bedwetting clinic back in Department of Urology, including pediatric urology, pediatric surgery with Dr. Gursev. And this is all about children of this part of the city and country who have got this. So there are awareness drives and there are issues which go to schools and to parents, teachers, meetings and all. So looking at this child, the first thing is to believe them. Also look at whether they are primary or they're secondary. I'll come to secondary a little later, but we're dealing with all the 3 primary children in their early teens. So we will look at their voiding diary as first step when they come back on the second time. And at the same time, look at getting the confidence building measures. They will not be treated by behavioral therapy alone. That is where they will have to get into the activity of understanding. We forget so many things which you have posted around is all those aspects, which includes, number 1, a good history taking. That includes, are they constipated or are they fecally incontinent? Number 1, very, very important thing, which we certainly all of us do miss out. We look at their past therapy, which they were getting some benefits, has been how effective and what was the medication. Many a times medication may not be the first choice. Number 2, number 3 is all those diseases which we don't see so early in life and we don't screen for. Mainly the thyroids and the sickles and the whole list of abnormality you need to look at. As a child walks to your room, you get to know that this child is possibly the 3rd child in the list today who's wet by day and night and wear diapers day and night. So he's totally incontinent. So looking into this picture, we will look at an evaluation of this. So by talking to the child, number 1, how much subdued is he and how much subdued is he morally, otherwise also. Looking at understanding the parents and how much are they caring for it and how much do they look into preventing it in terms of not giving 2 glasses of milk before his bedtime rather than giving it 2 hours before his bedtime, whatever they have to give as a water therapy. So you pick up a lot of things around. Is it a physiological polydipsia and a polyuria kind of picture created around? Finally, when you're looking at primary nocturnal enuresis, which could not be managed till the age of 5 and probably from 6 to 15 has troubled both the child and the parents, you got to look at a voiding diary. It will give you a lot of idea about the nights they are wet, the nights they are wetting twice. They're going to look at what kind of food and water habits. Do they have a late night dinner as late night as midnight in some maximum cities? We look at, are these children only addicted to tea, coffee and issues which are going to be too diuretic kind of thing around. So that our cornerstone will be talking because you pick up everything on talking. There's not much on the investigation when you look at a monosymptomatic enuresis. But we had a child number 2, 1B, which actually has got daytime urgency and urge incontinence, and she is almost scared to go to school, which means that there is an overactivity complex too. Now, when we look at the larger picture, we want to look at how does she pass urine, what is the flow pattern. It's not easy for all children to do a uroflowmetry, but we pick up all those pictures, which is so important. So to talk, and the mother says the child passes urine well. The boy child, the mother can see a stream. For a girl child, it's all hush-hush in a washroom. You do an ultrasound and a post-water CD and pick up now. But it rotates around the history. So you will concentrate too much on the voiding diary, which gives you all the pictures. Her time of intake, her time of output in daytime, her night time, how many times and how many days a week is she bedwetting and is it twice a day. Remember, there are 2 patterns of such patients. Some are very deep sleepers and some are nocturnal polyurics. That's only 2 classes. The 3rd class is that the bladder capacity is not adequate. And these children will have daytime symptoms also. So imagine if the bladder capacity is on the lesser side functionally, or the bladder is overactive. That means it just contracts like a shaitan bacha and just doesn't let the bladder happen in daytime, like the child number 1B, urgency and urge incontinence in daytime. And having also nocturnal urgency along with enuresis, which is sadly the child cannot wake up. We are looking at the component of overactivity of bladder. So there's an overactivity component of the bladder, number 1. Number 2, there is a deep arousal or deep sleep mechanism which is ingrained in the body of this child. And number 3, sadly, is a nocturnal polyuria as a very important key component. If you identify all the 3 things separately, lot by talking, lot by bedwetting discussions, and you pick up all that, then you are in a position to move forward. That means you will look at attempting yourself on those therapies. So rightly put, I can see those slides and I'm just letting them go because our audience and my colleagues, respected colleagues, are able to look at that. So we're looking at all those other issues where a child is too obese or having rhinosinusitis, and these are things which happen around. Remember, if there is only one parent who had an enuresis as monosymptomatic, the chances are the child could be 14 to 24% possibility of it. If both the parents had, there's a 44 to 70% incidence, the child will be anuretic. So therefore, if the parents can be counseled about this, and remember, don't forget, there are also premarital counselings and counselings for infertility too. We don't ask them this, but these are all things which are ingrained in our practice as to how much we can stretch ourselves on counseling and history discussion. So if both the parents had, there's a possibility that bedwetting is almost going to be component for all the siblings unless the behavioral therapy is ingrained very early in the practice. So Dr. Sanjukta, to bring about a therapy for these patients is reassurance, reassurance, and reassurance, number 1. Number 2, identify with the voiding diary, identify with the activities and the capabilities and constipation issues as to what are the aspects we need to look at. If it is a monosymptomatic enuresis only, bedwetting only at night and day is absolutely fine, Dr. Pandey. Then we look at getting into the understanding whether it's a deep arousal, and the mother attempts to wake the child 1.5 hours and 3 hours later, the child refuses to wake up, or the alarms don't work in the child. Number two, or he's producing too much urine at night, which a lot can come up by the way of voiding diary. Now, the voiding diary in an ureteric child is impossible unless you weigh the pads and look at weighing the pads and finding a difference out, which is too cumbersome and not easy in practical routine. And finally, at the end of it, if you only get to know the child is producing so much and getting wet twice, whereas had dinner at 8 o'clock and slept at 10 o'clock, that means must be nocturnal polyuria. You pick up all that from a deduction of what you look at. If the child gets up at night and has nocturnal urgency and has got diurnal urgency, then it's possibly something where we need to look at the overactive bladder. So the large picture of this will be in history only. It's up upon us how much we can spend time on talking to that. That's one aspect. Number two, if you have a child who has got non-monosymptomatic, that means daytime symptoms of urgency, frequency, and some other symptoms attached to it, which includes dysuria and burning, you would like to rule out a urine infection. That means you do a proper routine and culture. And that's where I just want to dwell for a minute. Urine routine and urine culture are to be told to the parents as to how to give a sample, not necessarily in enuresis alone. If it is an overactive bladder component and daytime symptoms, then you want to rule out an UTI. But let's not get into the A to Z of scenarios of evaluation for a child, which will actually take away the entire thrill of treatment, but keep evaluating and finding incidental results. So urine routine and cultures may not be required for a classical non-monosymptomatic, non-UTI looking picture clinically. When you have a non-monosymptomatic, that means you have got daytime symptoms, you will do routine and culture, you will do a sonography, you will look at a uroflowmetry and a voiding diary for all patients who come wet or who have got overactive bladder components or who are at this point in time looking at this. So we are looking at this evaluation and we go to treat. So on day one itself, we may not understand everything, but nice to have a parameters because you look at sickle cell, you look at diabetes, parents are diabetic. So nice to have a blood evaluation to show them your reports are normal. It's all about your vein and bladder rhythm and we're going to go forward. Frankly speaking, I don't do all these evaluations on day one. I look at only understanding the child for a while. When I can't understand a child because the child is 6 to 9 years old compared to 11 to 15 years old, I understand the parents and their concern and why they came 2 years or 15 years late, attempted therapy and stopped. So a lot is in the mind and the body language of the parents around. Finally, we will look at two aspects of it. If we pick up nocturnal polyuria, we will look at that aspect of treatment, which will be by a drug called desmopressin. If we look at arousal mechanisms that we get involved parents because children are too small to be looked at. While they have toilet trained their children so well in the daytime, they should do the same thing at night. And that's where it comes to the behavioral therapy for this kind of an aspect, where we'll work hard on looking at their dinner and their sleep, give a gap of 2 hours, 8 and 10 kind of thing around, at least in city of Mumbai, where they would agree to eat at 8 o'clock and not at 10 o'clock. They would sleep 2 hours later, restrict the evening fluid intake, the beverages of tea and coffee, which starts very early in lives, and many of the children today should be restricted because they also happen to be both bladder irritants as well as diuretics. So we're looking at the larger picture of looking at the patient getting involved in therapy. In all quality of life diseases, whichever you treat, overactive bladders and enuresis, you involve the parents and the family so that at the end of it, when you look at the voiding diary after 2 weeks and 6 weeks and 3 months, you say you are cured. Look at your voiding diary. That's your report card that you created and brought back to me. So voiding diary has got multiple aspects. One is it has got the aspects of understanding the entire behavioral therapy of drinking and eating and the leakage and incontinence. It also gives you a result aspect later on. So we're looking at the large picture of voiding diary will be a part of the journey as a patient comes back after 2 weeks and after 4 weeks and maybe after 6 weeks and 12 weeks. So that's how we follow. When it comes to pharmacotherapy, we're looking at two important components. If there is a picture of overactive bladder, like the children having daytime urgency, urge incontinence and frequency, these children will deserve to be looking at some kind of an antimuscarinic, some kind of an anticholinergic therapy if behoves the clinician apart from the water intake, because that gives them a morale to go back to school. They're not wetting. They're not wetting in undergarments. They're not smelling of urine, etc., etc. It's a huge morale booster for children around. Remember that. And so much is hidden and silent, sadly. The other aspect is the nighttime therapy, and that's where we look at desmopressin. It's available in the country as both melt formulation as a tablet formulation. The dosage for children could happen to be 120 microgram as a melt formulation, where you keep it on the tongue and it melts across. It is to be taken regularly, and I prefer giving it not necessarily with food timings, because food has nothing to do with it. It dissolves directly from the tongue and gets submucosal straight away. So to me, it's a regular affair. We look at these patients with nocturnal polyuria only benefiting. So as a blanket, giving everybody the therapy will not work. Number one. Number two is deep arousals, maybe maybe doing an ureteric twice or thrice at night. Parents get tired. So this kind of patients will look at arousal mechanism changing. These kind of patients will be looking at a whole behavioral therapy at home, and also a little bit of pediatricians getting into and making the child. But this is also related quite too much to the arousal mechanism. In India, we don't have those alarms, which are alarms where a child will vibrate and wake up. The parents need to wake up. So let's get parents involved in beverages and everything, including the tablet form. The patients do come back, you follow them very closely, you look at escalating and de-escalating therapy. Children have gone to even 240 micrograms in my therapy, gone up there, completely been dry. They have got the confidence building. We have de-escalated over 2 months to 3 months around and kept them to a baseline level and understood if we can de-escalate. De-escalate of desmopressin is again a complete therapy where we start in de-escalating the dose and de-escalating timings. That means we go forward and restrict them taking it every day. We make it alternate days to start with, and then twice a week kind of thing, and gradually de-escalate it. While doing so, if you look at de-escalating in these months, which are monsoon or wintry months, the children may turn anuretic because they don't sweat around and their water and sleep patterns are a little different. It also behoves that we back at Kokilaben Hospital and all those who are running bedwetting clinics in the country have seen more of these patients do come because the family is living together and there are changes being seen and the stress at home is also brought about that picture. I must stress at this point in time, beyond the 3 wonderful cases you showed around, there is one child who is a secondary anuretic. That means she's a girl who was anuretic till 6 to 9 years. But then after all the therapy that Dr. Sanjukta gave in Kolkata or I gave in Mumbai, the child became completely dry. 3, 6 months, 1 year, 2 years later, she comes back to any of us in the country and says, I was treated, I was doing well, and the child is anuretic again. She sometimes bedwets twice a day and sometimes 4 times a week. You got to look at secondary anuresis always as a cause. And that's where you're dealing up with the grown-up children. Very, very important now to spend more time with them rather than taking the next emergency on, which means we got to identify all the causes. And the causes could be anything. It's so much in the mind for this child right now. A change of school, a kind of stress at home with parents fighting it out, and that's one. Divorce, etc., etc. Constipation, new onset constipation. Sadly, sometimes sexual activity, molestation, and sexual abuse have been defined as factors in this country, in this very country, as silent suffering of children, which actually could pronounce as secondary anuresis. So that factor has to be kept in mind.
Thank you, Dr. Sanjay. I think that was quite comprehensive. From a pediatrician's point of view, I have a feeling that the parents who come to the bedwetting clinic, sometimes their only aim is to get a medicine and to stop this suddenly. I mean, they want a quick cure, and that's the thing. They have been through the whole gamut of going to different pediatricians, trying out different things from Ayurvedic to homeopathic to anything that the neighbor suggested, and they want a very quick cure. And the first thing we have to do is to unravel them with the history and try to convince them that there is no quick fix. And that is the most difficult undertaking of it all. And the second thing I find with some of the parents is, even after telling them multiple times not to stop the therapy, they might stop the therapy once the child is well. Or the other contrast is they do not come for follow-up, but they continue therapy for months on end. So that these two issues are always going to be a problem in bedwetting clinic, and a lot of counseling and a lot of hard work goes in trying to convince the parents to stay with us and continue with the therapy. So
well said. Absolutely true.
Yeah. So another thing I'm facing quite a bit now, especially with younger children, we always see as general pediatricians that say 5 or 6 year old boy who has been toilet trained at 2 years, and he's absolutely toilet trained and he doesn't wet the bed at night, but suddenly he starts visiting the toilet frequently and passing small amounts of urine. He goes multiple times, maybe 22 times during the day. There is no dysuria, no burning, but he's going and passing small amounts of urine. And this happened with one of my children who I knew from birth. He was living with his grandparents during lockdown because mother was a nurse. There was behavioral issues present. He was getting very upset because he was living apart from his grandparents, from his parents. And but still, in spite of no dysuria being there, I did do a urine routine and culture, which was normal. But in spite of trying to do behavioral therapy over video consultation, because that was all we could manage, because he was there in Durgapur and I was in Calcutta, and so were his parents. So he continued to continuously go to the toilet multiple times. So this was a very specific case. But apart from this, I see other children also who have this issue only through the day, and the child is actually continent, never wets the pant, and he is actually continent at night as well. So what would be your suggestion about treating, managing, or doing any investigations for such a child?
So nice. Good. Remember, your first slide on this case talked about a 5-year-old child. As I in the beginning said, India lives beyond the metro cities and smaller suburban towns too. And there is an aspect of breastfeeding happening for a longer period of time and then weaning off and then coming into an age. The children are too much under parental care in the economically downtrodden society, sadly. Many of these children would complain of other things too. But out here, you already done a urine routine and culture. You moved one step forward and you've shown that there is no pyuria. There is no inflammatory picture in terms of dysuria, pain, burning, suprapubic discomfort, complaint around. But you talked about the child actually living with grandparents. It's in a state of lockdown where the child cannot go and see the sunshine and play the kind of gilli danda he was playing outside. So child is also a little suppressed, number one. Number two, he doesn't have his ways of school and his schoolmates and friends around. They're looking at aspects of two kinds. Number one. One is the behavioral aspect, another is a pathological aspect. So going through a trauma which he cannot speak up at this point in time for umpteen reasons, and as I did this quote in the secondary ureteric group kind of thing, is one aspect should be kept in mind by all of us when we look at children who are growing up and grown up and are living not with their own parents, because grandparents are too elderly and there could be other people around. But two important pathological aspects, number one, could be a bladder stone, because bladder stones happen post-weaning time when the vitamin A deficiency brings about nyctalopia in your understanding, brings about shedding of epithelium, and there are those nidus where stones do form. All my urology colleagues and my pediatric surgery colleagues in the lifetime have seen suddenly a stone coming from nowhere, the child is tugging at the penis, you find some mild hematuria or even no hematuria, or you pick up that only when you do an ultrasound. So when you've done a urine routine and you find no RBCs and etc., and his body habits were good enough, and I found that an ultrasound can be done as a KUB pattern, where you look at just the bladder and kidney ureter, looking at things are fine, which should come out fine because he has developed into a complete milestone boy. I would look at overactive bladder as my final diagnosis in such situation, where there are no other causes which I would like to really push deep. The first thing is to bring about a symptomatic cure, as you did demand, which would give about a confidence building in this child. Wetness is a different phenomenon altogether, both for grandparents and for the child who's losing it out 20 times a day. So out here, the drug which has been studied most in pediatrics today is tolterodine. It's a great drug. If my colleagues have not been using around, but that age group, tolterodine 2 milligrams once a day in the morning with breakfast, an early breakfast, is good enough for dose. I know that if children are a little smaller than that, we have also used 1 milligram tolterodine twice a day, morning and late afternoon. But 2 milligram loading dose in the morning is a good thing for that 15 to 20 kilograms boy who's 5 years plus kind of thing around, and it will work in his favor to settle the insanity of the bladder's excessive contraction, which is not because of a UTI, which is not because of a stone, and the child is not an urogenic bladder. So at least an ultrasound showing a post-ward residue close to minimal helps you to look at, okay, imaging wise, the kidney ureter bladders are normal, there's no bladder stone, there's no bladder wall thickening. You wish you could do a uroflowmetry, a test beyond it, but by his understanding that the flow and all has been good around, the bladder is empty, you could just give him 2 milligrams of tolterodine. Pediatricians consider oxybutynin as a wonderful drug. They have used it across the country. It's a wonderful drug. The only issue is this child will have more thirst and he will drink more water, he will drink more juices, more things required, and he will produce more urine. So all these anticholinergics in the past era have actually had this important aspect of, number one, cognitive dysfunction, more in elderly than in children, and number two, a lot of constipation and dryness of mouth. Dryness of mouth and constipation are two things you really can't decipher in a child till you pick it up and understand it's already too late. So to me, the drug which I have been using right now is half tablet of solifenacin. It's a great drug. The chances of it by default causing least amount of dryness of mouth is solifenacin, and that actually works in our favor. So it works very good for our patients. So you could do a 2.5, that is half tablet in the morning every day. There will be no dryness of mouth and the child will be good enough. I'm more than sure that that works with you too. So if you use 2.5 milligram solifenacin as Soliton or any other brand you know about, give it once in the morning every day as half tablet per day compared to the adult dose of 5 milligram, it works well. Or 2 milligrams of tolterodine. Give it for a week and look at the warding diary, which cannot be measured, but you get to know from 22 it becomes half, 10 times, and then it becomes again half. While all patients, which could be women, children, elderly, we are treating them for overactive bladder and giving the bladder a sanity. We should be careful that they don't have warding dysfunction. We should be careful that we don't raise the post-ward residue to a level which they will not complain will be picked up on ultrasound later. Therefore, you did a screening ultrasound, you found no stone, you did that job, you put him on tolterodine, saw him after 2 weeks. If then he complained, please come back earlier. But remember, every passing day he's getting better because these are strong and wonderful drugs. 2 weeks later, he said you did magic, auntie, and that's it.
Thank you, Dr. Sanjay. Just one thing, I remember I discussed this case with you because as any other pediatrician would do, I tried oxybutylin, and what happened was what you said, that the child became more thirsty, was drinking too much, and it wasn't working. And I tried tolterodine and it did work, and didn't manage to do an imaging for this child straight away because of lockdown issues. But one query for all my colleagues is from on behalf of all my colleagues is, how much of post-void residue would you consider significant? And should it be that we should always do an ultrasound before starting medication? Like
Wonderful question. And for all my colleague pediatricians who could be in the yearning years and senior most colleagues with whom I respect everybody, and my salute to all of you who have taken this challenge of taking so much of pediatric work in this lockdown for the last 4 months. It is a challenge all the time when we look at imaging. Imaging, what you're talking about, Dr. Sanjukta, is an ultrasound, and ultrasound is an imaging which is an observer-oriented imaging. In an adult like you and me, we know how to hold a bladder, etc. But for a child, holding the bladder is not easy. This child cannot hold bladder. Your interest is only to look at, are the kidneys good? Are the ureteric jets looking good? Are things looking good? When you are getting into a functional disease, you don't want to miss anything pathological and organic. As I said, a stone, even a vesico-ureteric junction stone, which can give you all the bladder symptoms, because VUJ is a part of the trigone. That trigone gets irritated. Many patients come and say that we have got this last 3 days of so much of trigonal irritation or urgency frequency. You do an ultrasound and find that the left side is hydroureter and there is a small vesico-ureteric junction stone. So imaging is a good idea when you're looking at treating a quality of life disease and not miss out anything bigger and organic. That you don't expect anything organic happening at 5 years other than a bladder stone, possibly a lower ureteric stone, which could cause a similar kind of trigonal irritation like a bladder stone does to a trigone when it comes and pops down there on the trigone. That's one. Your question on urodynamic studies is very interesting. It actually would take some time, but I need to answer that. Urodynamics is a dynamic change happening around between the understanding of the bladder and the outlet. So the bladder contracts, the passage open and urine comes out is what you explain to a patient. Something gone wrong, either the bladder is not working or the bladder is overworking or the passage is choked or the passage is open. Any of these 4 combinations or a combination of these worsens around, and you can't know by history and geography because everybody adjusts. When you and I gracefully age, our black hairs will turn gray and will adjust it slowly every passing day. Similarly, a child adjusts to few things around. Urodynamics is done when you are not able to satisfactorily pick up things progressively in your evaluation, which is history, examination, and non-invasive imaging. Urodynamics is an imaging study required even at the outset for a classical neurogenic bladder, which was your case number 3, 1C, the child who's wet all the time. A completely wet child living at the age of 14 with diapers. Are we missing something? He may be wet, that means he's emptying completely. You may do an ultrasound only of the bladder and find that the bladder is empty. If you go up the kidneys, you may find gross hydroureter nephrosis and you're bold. What happened? So a child may complain of fever, but mine and your job is to look at, is it pneumonia or is it COVID or is it tuberculosis? The child complains of a complaint. We got to pick that as a between the lines around. Similarly, this child who reappears after some time and may continue to have symptoms or continue to have baseline symptoms, but our medicines have only given that much result. It's nice to look at why has he not completely resolved. If we gave him sweet, why is it tasting salty to him? So we need to look at a study. Now, again, urodynamics is from non-invasive to invasive. The components of urodynamics are, number one, avoiding diarrhea. Number two, a uroflowmetry. And then comes the pressure flow study, which you have labeled as urodynamics, is an invasive study. So an invasive study is required when the history, when the examination, that's a great slide. Yeah, you can keep it there. So that is an invasive study is required when non-invasive parameters are not given the answer that you look for. Let's look at these two important tests. I mean, for a child till 10, 12, 12, 14 years may not be doing uroflowmetry, but let's talk about this. Very important when you talk urodynamics. Ultrasound KUB is an observer-oriented investigation. An observer, a respected sonologist in partially full bladder examines the kidneys, the ureter, the bladder, the ureteric jets, and the bladder wall thickness, the pre and the post-ward residue, maybe more things around, but that is what is picked up on ultrasound KUB. The patient goes and passes urine in the washroom and comes back after 2, 5, 10 minutes, and the post-ward residue is picked up. Nobody ever knows the dynamic change which happened when the patient voided. And what was the dynamic change? The bladder contracted and the passage opened. And that is tested by uroflowmetry. Metry is measurement, flow is speed, and euro is urine. So uroflowmetry to me is as much as ECG of the bladder. In other words, if you have a chest pain, the first thing is to do an ECG and identify whether it is angioplasty or a CABG. Similarly, if the patient is not passing urine very well or obstructed or things going wrong, uroflowmetry tells all. It gives us an idea as what is internally happening, a combination of bladder and outlet issues. And the urodynamics could be possibly the next step. So the urodynamics that you talked about is invasive study, which is done under antibiotic cover because they're invading a urinary passage. And that is something where we leave the transducers to pass the information what is happening inside the bladder during a filling phase and a voiding phase. So dynamically, as the bladder fills and the bladder sensations come up and the bladder empties, we get to know all the answers. So you would need a urodynamics only when the child is refractory overactive bladder. Coming back to your case, the child has been given tolterodine, the child does well, but not completely well. You could look at the alternate drug, which you could go one step higher, which could be solifenacin 2.5 milligrams, or you could add something like an imipramine kind of thing around, or you may escalate the dose if required. While you're doing so, you talked about this question, which I've not answered yet, is what is the significance of post-ward residue? An isolated post-ward residue, which is low, has got great meaning. An isolated post-ward residue on ultrasound, which is very high, may not have much meaning. The reason is the patient was asked to hold too full a bladder by the sonologist while the sonologist was busy. In too full a bladder, even a normal man like you and me could even not empty the bladder completely. And the residual volume being very high could just be an end result of something else. A uroflowmetry with a residual volume tells how is the flow and what is left over. Ideally, the normal residual volumes, sorry, for you and me could be anything between 20 to 50 to 75 ml, acceptable to me. But that in the background of a good uroflowmetry will tell me so much. It will tell me how the patient passed urine and how much is left over in the bladder. Compared to only sonography, when we never know what was a patient in a state of when the patient was passing urine. So uroflowmetry is stronger than ultrasound when it comes to lower tract evaluation in terms of voiding, in terms of dysfunction, in terms of studies. It with the imaging study ultrasound and voiding diary would finally take you forward on a patient whom we are treating with behavioral therapy and with anticholinergics, which could be as good as solifenacin, tolterodine, oxybutynin, probanthine, etc., etc. So finally coming to it, patients with residual volume more than 1/3 bladder capacity for any age group would actually be significant bladder capacity. If I talk for an adult, 150 ml is a very significant bladder capacity because the ordinary bladder capacity is 450 ml. Similarly, in a child with a PVR alone of 50 ml or 75 ml consistently, in the background of an obstruction is a high post-ward residue. Compared to a child who has got frequency urgency, it hold nothing, the bladder will be empty. And it will be easy for you to then start him on a full dose therapy, come back and see after 2, 4, 6 weeks the post-ward residue, and you're happy you've not obstructed the child while you treated the child. Yeah.
Yeah, thank you. Now you take a break while I go on to the case 3. Yeah.
Right.
So this is a 1-year-old child who came with a history of continuous dribbling and came from a village where obviously there was very little care she got since birth. So initially, the passage of urine was considered to be normal. Interestingly enough, the diagnosis was made by the grandmother, who said this was not normal. And the fact is that the child is continuously passing urine. And when she came to me, she had an apparently normal genitalia. And I noted that the urine was actually coming from the vaginal opening. So, what investigations I would do? The point often becomes that when a child like this comes to us from the peripheries, they've already got of, they have brought their last resources with them. You can't send them to different hospitals. You have to use your, whatever resources you have got to make a possible diagnosis, and obviously then refer on to the appropriate specialty. So here I would request you to just go ahead and tell me what is the best way to proceed.
Perfectly fine. So, respects to you and entire set of pediatricians who take such a holistic view when a child comes in around. And my huge respect to all pediatricians who look at child, mind and body, society, social rearing and parents and the economics behind it. It's such a situation in our country. So looking at this child coming from a suburban rural area and 1 year with continuous dribbling, the good news that you've given me is your examination find that her genitalia is normal. She's not an ambiguous genitalia at the very outset to start with. Number one. Number two is the urine is noted coming from the vaginal opening. That means it's not very easy to diagnose a vaginal opening and a urethral opening in a clinical examination in a child in the outpatient department, but you know that it's coming from much lower down. That's what you could, with a child allowing you, with the parents helping us out. So that is what it is. And she's continuously dribbling, which means that there are only two possibilities. Number one, it could either be an ectopic ureter or it could be a congenital vesico-vaginal fistula. Therefore, my question to you will be how to play a part between these two. Either it's an ectopic ureter. An ectopic ureter will be one of the ureters of the two ureters is opening ectopically behind the control mechanism, a distal to control mechanism, which is beyond the external sphincter. And it could even be opening on the intervaginal wall, which you could pick up that you've done it already. Number one. Number two, the possibility of a congenital vesico-vaginal fistula, though a rarity, but still, I've seen two in my 24 years career, and I wish and pray God doesn't give them that at such an early age. So if that is a possibility, you could ask them a question. Does the girl also pass urine or continuously dribble? Number one. Or so if the girl is also passing urine and leaking continuously, that means the bladder is also filling up. So the control mechanism is partaking in the bladder control of the ureter, which is coming from opposite side and is controlling around. So that could be an ectopic ureter where you have passing urine well and leaking continuously, where one side leaks continuously. Other way around, if she is a congenital vesico-vaginal fistula, because of the Mullerian issues which has happened around, she'll be leaking continuously all her life. And therefore, what best would mean is an examination under anesthesia. I mean, obviously, an investigation as good as an ultrasound will tell you that upper tracts are normal or there's a hydroureter nephrosis, and those could be your bouncers later in the afternoon, in the evening today. But very clearly, this looks like a child who has dribbled since birth. And if you could have told me that the child passes urine and still gets continuously wet, ectopic ureter, child is continuously wet completely, it's a vesico-vaginal fistula, which is a congenital vesico-vaginal fistula. Ultrasound, number one, there are no reasons to do urine routines and cultures. You can't do one, you cannot pick the right kind of a situation of a vaginal fragment that is coming in. You would look at your colleague pediatric surgeon, your colleague urologist who would do an examination and anesthesia, which is examining, number one, that you will be a part of in the operating room under a short anesthesia, a cystoscopy, which will be very important. There are times we give a tablet called pyridium, which colors the urine orange, and we know where is it coming from. Or there could be ectopic orifices somewhere else, which is difficult to find. So tablet pyridium is given before the patient comes to the OT, a few hours or 6 hours early, and you find the urine is all dark orange Mirinda color coming from the ureter which is involved. So examination and anesthesia will tell us all, obviously ultrasound and basic evaluation of stuff, because she's born with an anatomical abnormality that she's presented to you at 1 year of age.
Thank you so much. That really cleared quite a few doubts. So I'll come to case 4, which is the 8-year-old boy. And this was the parents persistently complained of narrow stream of urine. I mean, they were quite very definite about it. There was dysuria, there was frequency, but there was no incontinence. On examination, there was no phimosis. Now the urine routine showed pulses 8 to 10, and the culture was sterile. Interestingly, because obviously they had had a half a course of antibiotics before coming to me. And ultrasound KOB, there was slight bladder wall thickening. Because of the 8 to 10 pus cells, gave a full course of empiric antibiotics for 10 days. The dysuria resolved. The frequency also resolved. But the parents continuously worried about this narrow stream. Now, the stream was fine, but it was, yes, it seemed to be a little narrow. But is there actually any investigation to do? Because they said they have other children, other boys, and this stream is different from the stream of urine of other children. I mean, is there anything really to worry? Could there be a ureteric problem, urethral problem that we need to worry about in this child?
Yeah. Wonderful. Actually, you're taking it absolutely pan subject. It looks like so. 8 years child. That means that parents have seen the stream. Now, the word narrow stream, that means there is a place where the jet is being created and it's narrow. Now, narrow is one. The other is a forceful stream. Narrow is the caliber. But the force is one where children actually, all boy child or a male child can actually paint on the wall, and that is what they measure themselves out. So this child, if cannot have a forceful throw and the force is narrow, what are the possibilities? Number one, you examined and there is no phimosis, retractable and hygienic, number one. Number two is routine shows 8 to 10 pus cells. I gather this routine is a proper midstream and a clean catch specimen because 8-year-old child can direct the stream without touching the bottom. Has some burning maturation. There is no way I would leave this child. It's so important. The investigation of choice is always non-invasive. Talk to the child. Say, next time you pass urine, pass in my toilet. I would just want to see you. Otherwise, the child is scared about you, let the parents record it. That's great. So narrow stream with a forceful. So narrow is one, decreased caliber and decreased force. Both of them point towards possibly an obstruction. Number one. Number two, I gather he's not neurogenic. I gather he is not obstructed, etc. So to me at this point in time, the test is visual evaluation and a uroflowmetry. Uroflowmetry tells all. 8-year-old boy is a grown-up boy. He could stand on the uroflowmetry, which actually is a computerized toilet. It's a commode. When you pass urine, A to Z, whatever you do comes out. If the stream is narrow and flat, if it's a flat stream and a narrow stream and a prolonged stream, then it's all about an obstruction to the flow of urine. And you always go retrograde. Because out here, the bladder is not too full. You have seen that the ultrasound shows a slight bladder wall thickening. That means in an observer-oriented study, the bladder is overworking. That's what I can tell you. The bladder is overworking and getting thick. And that's one sign, but not a sign of neurogenic bladder. There are no cellules, there are no diverticulae. There's no upper tract issue here. The residual volume, not mentioned me, the residual volume is close to minimal. So all those are plus points in our favor for this 8-year-old boy. But if he has a poor flow, the next test will be called ascending urethrogram. A test where we do an X-ray study, a child lying in 30-degree recline, to put contrast to the penis, to the penile urethra, and assess the caliber of the urethra, understand it. So we always do non-invasive to invasive. We talked to him, we saw his uroflowmetry, graph. When he saw the video, which the uroflowmetry is, we get to know a lot of it. He could diagnose whether he could be this or that. 8-year-old boy with that kind of a slight bladder wall, I may not think, but could also be a very low-grade posterior urethral valve. I should not keep my eyes closed. For example, just to give you a little analogy, if a 55 years or 60 years old man comes to me and his prostate has enlarged to 70 grams or 100 grams, but he for the last 30 years has been straining to pass urine and he had a road traffic accident, I should not forget in my mind that this patient could be a stricture urethra for the last 30 years. Today his prostate has enlarged because of age-related hormonal changes. I will not look at the prostate per se, but look at his history of 30 years of straining. So this child has not something of that kind where the mother says, but that you said narrow caliber of stream, I would also not miss out a possible posterior urethral wall. Therefore, my ascending urethrogram is attached to an MCU. So ascending urethrogram plus MCU tells all. It's so much of an imaging that is picked up around. So these are dynamic studies. We're not entering urodynamics. So these are dynamic and anatomical studies which we do, and we pick up most of it. To a stricture urethra, we may have to look at what, how, when, where, and why did a young boy had a stricture? Did he have a boy's bicycle injury, saddle injury kind of thing around? Something of that kind? Or it could just be a poor flow, but everything is looking good. Or parents look at poor flow and you show them a bell-shaped curve. So there are many analogies to it. Finally, a uroflowmetry, an ascending urethrogram and an MCU, because a poor flow may not only be a urethral obstruction, could also be a hypocontractile bladder as a result of an occult spinal dysraphism, which is not visible to you and me at all, even on examination. So ascending ureterogram and MCU could be the last test, and possibly if there are any doubts of it, or even if there are no doubts or the doubts are pinpointed, a cystoscopy or a urethrocystoscopy and anesthesia will reveal all and treat all.
Thank you. I have no doubt in my mind that if I get a case like this, I need a pediatric surgeon or a urologist to sort it out. I mean, this is right out of my league. So the important thing, I think, is to kind of have not dismiss the parents' concern, but to take it on. I think that is the most important thing, because if the parents are concerned, they usually have a point.
Perfect. So can I just add here, because this is a great case. Let's not take it lightly. It's a great case, frankly speaking. Urine routine examination showing pus cells 8 to 10. Can't take it lightly. I wish pus cells were named as WBCs now, that I've applied to American Association requesting them don't call it pus cells anymore. They're inflammatory cells and better to name them WBCs. That means there's an inflammatory component inside. It could be a stone in the bladder. It could be a stone at the VUJ. It could be an inflammation of some kind we have not picked up. But a pediatrician examined a patient and looked at no phimosis, did a proper urine examination which showed some pus cells, but the urine was sterile. Had it been a middle-aged sexually active male, I would talk of urethritis and chlamydia trachomatis, etc., etc. So the poor stream behoves that we take it to the highest possible level, and as you rightly said, believe the story of the history which the parents give. So that's fine. Completely okay. Go ahead.
Thank you. So let's go on to case number 5, where I think this is one of the commonest scenarios we pediatricians face, that where we have a 3-year-old boy with vomiting and high-grade fever, and as a part of a workup for infection and for fever, we always do a urine routine. I mean, this is mandatory for us.
Yeah.
And there we see that there is 40 cells per high power field, and a culture that has been sent off. Very important to say again, a midstream urine, do not start any antibiotics. So one thing to reiterate here, that if we start antibiotics, we might not get a growth. So it shows a growth of E. coli 10 to the power of 5 per HPF, which is significant. And on physical examination, we find 2 things that are contributory here, that the child has a loaded colon and a very tight phimosis. And there is a history of habitual constipation. So we all know that constipation does per se affect the urinary tract and can lead to infection. And we also know that boys, especially the younger, they are more likely to have an anatomical problem if they have an infection. That is an UTI, and a tight phimosis will also contribute to urinary retention, should I say, and infection. So what are your thoughts on this? And once we have treated the urine infection properly, how do we go about treating this child, and what role do you think that phimosis surgery has for a child like this?
Yeah, so that's a great question. That's a wonderful question, and let's look into that with a little bit of, because the kind of secular situation we live in around, we have children who are being religiously circumcised on one aspect, and we have children whose parents are not aware of the situation called phimosis. So parents who come in around many a times may have been too aggressive in trying to pull back the skin and cause injuries too, which is not required in the early years around. If a child has got a febrile UTI and an evaluation looks at that is the one which is the cause of it, then circumcision is almost mandatory. And therefore, circumcisions at the age of 6 months, 6 weeks, 1 year, 2 years are more related to that kind of a situation where there is a recurrent UTI or a febrile UTI. And remember, you can cut it down 10 times lower by just doing a circumcision. That means if you identified a cause, then you picked up already, because the phimotic sac and the prepuce harbors those bacteria which are completely not innate to the internal environment. Not that there are any bacteria sitting in the genitourinary tract otherwise. It's being soiled by the external environment of the bacteria, which could lead to a child from getting a febrile UTI. So there could be add-on causes too. And therefore, while you're looking at phimosis at the age of 3 years, and you know that the physiological adhesions from 3 to 5 years lies themselves out of the mother's practices of attempting to retract it gently, applying some coconut oils and some petroleum jelly, etc. You prevent an aggressive surgery without having looked at the other causes. So you have a child who's febrile, who comes with it, you evaluate and file that the the constipation could be recent onset or could be habitual constipation. I mean, a child with fever, not feeding well, running high fever, is coming down and out and maybe constipated too. So your one examination and mother's history about habitual constipation can be taken into consideration as the child is still in learning period, 3 years, number one. Number two, at the age of 3 years, phimosis would deserve to be looked at with a pinch of salt. That phimosis, which is not an occlusive phimosis, which does not balloon the phimotic sac, is something which can be looked at. That means you can examine it, you can teach a hygiene to a parent, you can look at how to take it forward. But if that is an occlusive phimosis, which causes a ballooning of the prepuce, which mother describes very well, she will tell you it swells up and that's good enough for you. That means you are actually playing against the very important aspect you did mention. It can cause obstructive voiding. This children is actually passing not to the exterior, but passing into his own body. He voids into his own body called the prepucial sac. These children need a relief. There are people who have come with metal stenosis or have come with completely occlusive phimosis to ballooning of prepuce and even hydroureteronephrosis into your clinics. Because children have loved without any complaints. They lived and loved, unfortunately. So that patient, even at 3 years, would get a circumcision. 3 to 5 years is a time when the physiological adhesion between the glands and it lies, provided the mother understands it, gently attempts to retract if it's retractable, maintains a hygiene, and it works very well. So that's one aspect of it. But neonates to toddlers who have febrile UTI don't have a cause of other febrile UTIs, which could be a vesico-ureteric reflux, a second important cause which I would look at when you bring such a patient to us. If that is not there, if the residual volumes are minimal around and you find everything else is good, except febrile UTI, which does not look at BUR and scarring and all those things, we go straight away and help the patient out by decreasing the chances of him getting another UTI 10 times. Before the lockdown, we did 1 to a child, and a child for the last 4 months is not febrile compared to 7 to 8 such febrile episodes with injectables in the last 2 years. So taking it forward, phimosis is a very tight game for a pediatrician. Looking at whether a physiological adhesion and a tightness not causing an occlusion or obstruction or not interfering with the hygiene at that age group, we will not look at doing a surgery straight away. We'll look at teaching a parent. We're looking at, if it's occlusive, there's no choice. You got to watch out if occlusion is doing what. For non-occlusive, I think we can spend our time. We can look at everything which is possible under the sun, from hygiene to watching everything before you do a phimosis surgery.
So I gather that if there is ballooning, then we should not wait. So that's why I put the age at 3, which is a kind of a gray area, because we often wait between 3 to 5 years. But if there is ballooning, we should not wait.
Ballooning and febrile UTI as a result of phimotic occlusive phimosis. I use the word occlusive phimosis. So that is one. I don't think we want to wait and give him more, because every UTI which ascends gives a scarring to the kidney too. So I think we're looking at the larger picture.
Absolutely. So coming to case 6A, a neonatal examination reveals a gland. This is quite a common scenario. So we do, I mean, it's one of the commonest congenital anomalies in a boy. So reveals a glandular hypospadias, and how should we counsel parents? Because immediately the parents are over the moon because a boy has been born, and then we counsel them that there's something wrong. And even if it's the slightest thing, often parents do not voice the concern, but sometimes I have been asked about future fertility and other issues as well. So how should we counsel the parents, and what are the investigations that we need to do in the neonatal period? Should we do anything? Should we wait? So this is case 6A.
Got it. Completely got it. So you want to go to 6B?
Yeah, case 6B, similar, but where we have a 4-year-old male child where the stream is going haywire, and there is a mild penile hypospadias, and there is a bend in the shaft with a, so the parents are worried about the future of this child. So what evaluation and counseling should we be doing at 4 years? Are we late? Are we already late? Have we missed anything in the management till we are waiting for 4 years? And what is the future for this child? Is there going to be any problems? So these are the two situations, one in the period, one at 4 years.
Dr. Sanjukta, it looks like you are bowling bouncers from Eden Garden to Wankhede. Congratulations. I mean, these are all wonderful cases. I'm impressed. I'm thoroughly impressed. You got the entire season. So let's move ahead. First, the neonatal child with a glandular hypospadias. Glandular hypospadias, my friends, is not to worry about. He could live a life without any trouble because it's still in the glands. It's not at the tip. It's just below the tip. It's not gone to coronal sulcus yet. So it's just on the glands, but granular. Granular comes with, sometimes they become grandfathers without any worry. But in today's modern world, where you are talking about two anxious mothers, one is a neonate's mother and one is a 4-year child's mother. It's all about counseling and saying that when time comes, we'll take care of it. There are larger pictures around. This child is a neonate. Let's take care of his immunity, his growth, his milestones. So talking in some way and distracting the mother away from a neonatal thing, because the neonatal glandular hypospadias in no way causes any major urinary deformity. Please remember that. Just compared to the coronal or to a mid-penile. So let's go to the second case, which is a 4-year male child. And he has got a mid-shaft, that means a mid-penile hypospadias. Mother has now seen that the child sometimes has these erections when the child is voiding. And she has seen some bend. And that bend is good enough for us to wake up to the whole thing. So she wakes up to two phenomena. One is, for the last 4 years, she has seen a child not passing from the tip, which the sibling would be or somebody would be. And now she sees a bend too. So anxiety is added upon compared to the neonatal's mother. So we look at the evaluating part, which is all about clinical examination. It's all about looking at talking and examination. Out here, it's a completely different picture. You have a hooded prepuce. You have a tip out there. You have a urethral plate, which is deficient. It is not covered on the ventral aspect and not taking it all the way there. So many of these children would require surgery for umpteen reasons, and therefore the timing of surgery matters. Normally, when we see even the most significant of the hypospadias, which could be even perineal and penoscrotal kind of thing, we don't push a surgery very fast because all we're doing is a reconstructive surgery. Remember, for any reconstruction, you have to bring somewhere cement and brick and probably get it happen around. And that reconstruction need to heal. Yes, for something where you want to direct a stream and let the child pick it up around, you get to the first stage. Sometimes you do a single stage, again, depending on what. For a child who is at this point in time, a mid-penile kind of thing, not too much to worry, but whenever the patient present, it's not too late. Because we do children, adolescent, adult, all kinds of hypospadias repair across the world, across specialties. So the plastic surgeons have done, pediatric surgeons have done, urologists have done, and there are a host of other colleagues who have practiced that and being practitioners of that. When we go more proximal, so these two mothers can be told the future could be very bright. Both of them will do very well. And when time comes, for a 3-year or 4-year-old child, the time has come. Because out there, the mother has talked about a CODI. And the CODI could have various components which a surgeon will correct. The CODI components could be straightening of the penis, called orthoplasty, and then doing a urethroplasty in the same stage and repairing it fully. So that completely behoves at this point of time not to go in. But if you have a penoscrotal hypospadias, if you have a perineal hypospadias, if you have got something of that kind, and in a male child, if you find one or two testes missing in the scrotum, I think it's time to wake up completely. That's where I wish parents also knew and do not wait till 3 years. Not that we'll operate them at 3 years. Then we possibly are looking at an intersex state. That's important. That's very, very important. One testis absent, hypospadias completely perineal, will not be a very great story. We need to pick up them early. Not that we'll start doing all the job in one, but identify that. So endocrinological evaluation, looking at these patients who have undescended testes is another ball game altogether. That means we'll involve ourselves and become endocrinologists. We'll involve our endocrine colleagues. Look at our surgeon colleagues. We'll assess them with an ultrasound, maybe an MRI, looking at where is this testis hidden, high up or low down there, or it's only in a clinical examination showing an inguinal testis. So with that, I think we can take it forward. So hypospadias is a correctable deformity. It's surgically correctable deformity. To allay the fears of patients, relatives, and parents when they come in around is very important because anxiety is about future. You very rightly asked, the child is worried about, will this child become a parent? Will the child become a male? Will he become a man and a male? Or he will be one sibling kind of thing around. So all those are more of LA, more of talking around, giving them a chance to see your surgical colleagues who are masters in the art in the OCT and all CTs around. And our colleagues, all pediatricians have their pediatric surgery colleagues and their urologist helping them out. So I think this completely behoves that we allay their fears, tell them the right thing, tell them time can wait, and nobody is late in hypospadias, please. Let's tell them very clearly. Whenever you come, the story starts ABCD. So it's completely fine.
Thank you. Now, another problem that has often surfaced, and if we miss the acute scrotum, like in this case of a 9-year-old child, there was sudden onset left testicular pain at school. He had mild episodes before. So he had mild episodes, but he felt embarrassed to tell his mother. And in the evening, when he showed his mother, there was some swelling of the scrotum and some redness. And the mother thought there's some ant bite or some insect bite, and maybe he had hit himself somewhere, and she just waited. And the next morning, they presented in the accident and emergency with constant discomfort. So what happened, the child was actually sent back, and the child came back after another 24 hours, when the child could hardly walk, and the child was in distress. He was tachycardic, he was in pain, and so for 24 hours we missed a situation which caused a lot of problems later on.
Yeah.
And how would you suggest we go about when a child presents to us with such a problem?
Perfect. It's sad that this happens around, and let's go to it. Number one, acute scrotum. Acute scrotum for a child. Sudden onset pain in testes at midnight or in school is all about to prove that this is not a testicular torsion straight away. There's no discussion on that. For all of us, everything else can wait. Now, there are two aspects to this entire scenario that you presented, which is painful. And I see it regularly in the last 12 years in Kokilaben hospital here. And in my 24 years career, right from CMC Vellore to JPMO Pondicherry to Ramachandra Medical College as associate professor, we have seen A to Z of this sad picture. So number one, parents don't know about it. Number two, they always wait upon it because the shame or the child is somewhere, and they would see the first doctor available who may not be the right doctor all the time. Why? Because why on earth a child would be treated as an epididymoorchitis when he has got no dysuria, he's not sexually active, there's no urethral instrumentation, there's no dysuria? Why did we label an adult diagnosis into a child? That's what is my request on this case. This is a wonderful case. So if you have an acute scrotum in a child, a quick evaluation is important. Everything else can wait. It could be an angioneuritic edema. It could be a, who knows, a testicular tumor, which is a hurricane tumor too. That's completely okay with us. But an acute scrotum in a child who had passed such episodes, sadly, is a torsion testis. The climactic reflex could be so strong at play, at games, at motions, at toilet. It could be a visceraptotic 9 years old child. The whole testis could turn around and may not be able to turn back like the last two mild episodes. If that happened, what happened? It was all Bellin-Clapper deformity, as a result of which this child's blood circulation was cut off. First the venous edema, and then the arterial ischemia, and finally the necrosis. So by the time the child comes to you postponed, for some reason, it's already too late. That's where some medical legal play always starts on. And I think we should wake up to, in today's medical legal era and the Google patient era, we have to be extremely careful about what we deal with such patients. And therefore, we are all partners as various cross specialties to talk the right thing for these patients, even if something goes wrong. Because many times the presentation itself will be late. You got to know that in 2 to 6 hours, the testis is so much ischemic that it will be necrotic, it will be gangrenous. So it could be 2 to 6 hours only. It also depends on how much is the rotation, which you can't derotate when a patient comes very early. So a patient presented very early that day itself, and the mother picked up the child, went to the emergency department. Somebody in the department can just derotate it. Do an ultrasound and look at the blood supply coming back. It can happen even on the ultrasound table too. Those are possibilities in an acute setup, which in our country we don't get to see, sadly. Number one. Number two is the child comes late. You will have to look at that point in time, not much is left. The clinical examination reveals all. The edema has gone from the spermatic cord into the scrotum, and you have a hemiscrotal edema, which is all not red because it's not epididymoorchitis. It's a tense looking one. Sadly, at that point in time, you will have to counsel the relatives and say that this is a progressive and a very fast moving phenomena like a urosepsis. And what has happened, sadly, is that the testis possibly may have lost it. We may do a quick screening ultrasound to look at whether the testis can be salvaged, but 24, 48 hours later, we normally expect not to salvage this. So we go in around and we do a proper orchidectomy on that side. But remember, the Bellin-Clapper deformity, or the deformity which behoves that this torsion happens, actually is an anatomical deformity of both sides. So while this 9-year-old child will possibly lose a testis because of delayed presentation of any kind, where antibiotics may have been given, or cold ice may have been given, hot packs may have been given, nothing should work and nothing should be tried, which we could transmit it to all parents in the country. Number one. So in that situation, we will do a contralateral orchidopexy. The child is left with only one testis. It does not hit us till we lose one, and then we know that we have only one left over. So it's very important for parents to know. And many parents come over at midnight and just cry and go back. And I said, nothing is wrong. You hardly know that you have got 2 kidneys or 1 kidney. Similarly, you hardly know that you've got one testis and one testis is good enough. So it's important to do good oculopexy, which our colleagues in the surgical fraternity will do it. They do it by a 3-point fixation with non-absorbable sutures. Many a times the parents may request for a prosthesis in due course of time, which could be placed by an inguinal route. So you brought out an amazing case. Thank you so much for this, because this is a bouncer. For all people around, we need to wake up to this phenomena that acute scrotum needs to be looked into. I mean, it could be even a hiatus or morgagni or some kind of appendages which could also cause a torsion. You can find a blue dot sign. You can do a lot of things. But when it comes to an acute phenomenon of that kind, let's not miss out somebody. Let's work hard. Ultrasound and wasting time is not required. This is one chance where we can directly go in and explore. Exploratory laparotomy and exploratory scrotal incision, nobody would mind. You could actually save a testis by exploring early. As good as that. Yeah.
Thank you. And the next case, and we often have quite obese children nowadays, and we have the situation where the parents are worried about the penile length. Often we have this situation where we see it's a buried kind of penis because of the obesity. But here I'm talking about a 10-year-old male child with all the milestones are normal. So 10-year-old, I would say it's prepubertal. Normal for age. The parents are worried about the short shaft of the penis, and on the clinical examination the child is overweight but not markedly so. The penis is partially buried, but still the shaft appears short. The test, everything is in the prepubertal phase. The child does not show any signs of puberty yet. So how short is short? And before puberty, when should we be concerned about the size? And should we wait till puberty to find out that whether the things will change? And how should we counsel the parents, of course?
Wonderful. Good one. Great. So micropenis is completely a subject. It'll not be possible to cover all, but I have a presentation done which would be on my YouTube channel, which possibly talks about A to Z on micropenis practical aspect. Here, you've got the right child, 10 years old. The parents have waited. They've seen somebody. Finally, they said, can I, from your, voice, know that everything is normal? If this child is not growing the way his sibling grew or the way I grew, etc. So the anxiety levels are very high. You actually tell them not to worry. It's all treatable whenever you came in around, and this child came at 10 years. You could have come 5 years earlier too, and you could have examined the same anxiety what you looked into. So when you put in the bed and examine you, as I rightly said, this child has got some prepubic fat. Number one, they're all these days, KFC and McDonald's children, and it's not uncommon that they have all chubby in their lower bottom down too. So examining is for multiple aspects. One is to look at the genitalia. One is to look at, is the entire endocrine picture looking good? That means the testes look good or not. The penile shaft looks good or not to you. The very clinical examination talks about the two testes are hanging, the scrotum look good around, and the penile shaft looks a little shorter than normal, and let's examine it. So that's where we look at something called as a stretch penile length. That's where a pediatric colleague will look into, and a urologist will look into a stretch penile length. If a pediatrician is not deeply involved into it, let's not sit into it, refer to a colleague who is doing this work in pediatrics, or refer it out completely to a surgical colleague who will say, not required to touch this or required to touch it. So measuring with a calipers, measuring with an examining ruler, etc., of a stretch penile length, very classically stretching the penis, and from the level of pubic symphysis on the dorsal aspect of the penis, if you measure it, there's a nomogram available for you which you can keep on your desktop. You could look at the age and look at stretch penile length. That means you're pulling the penis easy and nicely stretch. You measure it and come into a level. So anything which is 1.5 centimeter or lesser, for all practical purposes of measure, would be a micropenis, number one. But you today are seeing so much of concealed penises and overweight children, you will not be able to define till you look at that aspect, number one. So looking at the hormones of a 10-year-old child may not be very easy to interpret and take it forward. But if you look at the testes, you get to know a lot. So if you have got somebody's testes who are cryptorchid, unilateral or bilateral or small testes, or you look at a primary testicular failure kind of picture, those pictures around, combined with the penile length, then you know that his pubertal growth will not be spurted by his endogenous testis, if that is what it is. And those patients, you will have to look at pre-pubertal rather than post-pubertal. So somebody who has got a good growth, good milestones by a pediatric calendar, and whose testis looks normal, his clinics look normal and everything looks normal, we can watch and observe and follow him closely. Compared to somebody whose testis and whose secondary sexual characters which have not developed in this child, are looking smaller. So that will go a lot by the testis itself. The testicular field and the testicular vase, that's one thing which I have used as a benchmark, because they don't have huge benchmarks. Every test will have a different kind of story altogether, and it sometimes becomes very difficult for us. So we look at a stretch penile length less than 2.5 standard deviations lesser than normal in a nomogram, which you will keep, you can pull it up and keep it on your desktop. You said that this is micropenis, and I will take it forward and show it to my surgical colleagues, and the whole story starts from there. If it's pre-pubertal, we do a hormone stimulation. If it's post-pubertal, we watch him closely. We give them enough respite, look at the hormones then, and then watch and take it forward as desired.
Thank you so much. The next case is very close to my heart, though this is, I'm mentioning a neonate here, but actually for my short cases in my MRCP examination in UK, I was given a child and I was asked to examine the abdomen. The child was 4 years old, and when I examined the abdomen, what I could felt like a bladder, a huge bladder. And I didn't know what it was. I mean, why should a child 4 years old have such a huge bladder? And why should acute urinary retention would never be given for a MRCP exam? So I was a little nonplussed. But I had been told by my pediatrician professor back home that I had to examine the back also as part of the examination of the abdomen. And I remembered what he had said. And when I examined the back, I found the sacrum to be missing. So from then on, I always make a point to slide my hand across the spine for any new child that I'm examining, and of course a neonate as well. So here I saw a child, a neonate with which I felt that the sacrum was missing, and the external genitalia was normal. The child was a female. So what is your thoughts on this? Because of course this child will need long-term management. So if you could say that in short, as we are running a bit short on time.
Yes. So this child, when you examine, will have a chronic retention of urine. It could be possibly even an unsafe bladder. I have a strong statement to make here. Every wet child could be very important for us to identify whether it's a safe or an unsafe bladder. All those bladders which are going through detrusor sphincter dyssynergic picture, all those bladders which have got detrusor instability or detrusor hyperreflexia are dangerous to the kidneys, number one. Number two, the lower sacral spine issue, which is what you are showing us right now, are issues where you can have a bladder which is too full, and the bladder being full, it would go all the way to the kidneys around and hit it. So this is a kind of a neurovesical dysfunction of the kind where you need to look at. It could be a clean intermittent self-catheterization, or it could be aspects which you need to look into. So these patients will have urinary and bowel problems, number one. Sacral agenesis is a very difficult problem because it may not come alone. It may come with many more aspects around. On an X-ray, you will find missing sacrum. On a clinical examination, you can put your fingers there and you put a dimple and you can identify all that. Sadly, the bladder is too full and nobody's complaining. In other words, the child has come with a pregnant bladder. So to catheterize the patient immediately and deflate the bladder may not be a great option. Ultrasound is a good option to look at what is it doing to the kidneys. And many a times ultrasound may show that bladder is taking all the brunt, number one, compared to the bladder is giving the brunt to the kidneys, and that's a sad story. These patients may have a high creatinine at that point, but it does not usually happen because the bladder takes a brunt and probably becomes a low motor neuron kind of a picture, where sensations are low, capacity increases, and as Dr. Sanjukta rightly pointed out, a very large capacity bladder. This behoves, it's a neurovesical dysfunction. Bowel has to be looked into, and we may have to go into clean intermittent self-catheterization by the caregiver. And thereafter, it's a full neurourological workup and looking at how to get it sorted. In short, you don't want the upper tracts to get damaged whenever you pick up. Always look into either a catheterization later on and studying with urodynamics of the bladder and giving it a picture of neurovesical lower motor neuron kind of picture, or giving a clean intermittent self-catheterization to a mother till time comes around for us to take it forward. And the time has already run out because this has not been a normal looking bladder and the bladder outlet. And therefore, for a while we evaluate and look at all the aspects, this is not one of a tethered cord syndrome where you do a detethering and you can manage this. It's a sacral cord agenesis. The lower motor neurons are close to extinct or not working around. Therefore, bowel will be an issue and bladder will be an issue. And I can probably touch this with a larger chapter of looking at how do we manage bladder and bowel. And therefore, we may look into young Montes and appendicovesicostomies, etc. also as an aspect if parents understand in terms of the bladder capacity and anything too.
Thank you so much. I think the biggest challenge here is when I found a child with sacral agenesis, been around for some time, to teach the parents about this intermittent bladder self-catheterization, and also to explain to them that this is what they have to do throughout life, because they always want a surgical or some other medical solution to the problem, and that's something they cannot accept. Now, case 8, we have a 3-year-old male child who has come into the OPD with left-sided undescended testis. This is quite a common scenario, I think, for my pediatrician colleagues. And luckily, in this case, I found the testis in the inguinal canal. It's a 3-year-old child. So should we investigate any further, or is there any medical investigation that you would suggest in this case? Or should we directly be referring on to the pediatric surgical colleagues? As we do this case, I will then interrupt you with some of quite a few interesting questions that have come up during this discussion from my pediatric surgeons, the colleagues, because I think it will be topical before we go any further forward. So
wonderful. Got it. Completely fine. We wait for the questions around. So to start with case 8, 3 years male child come to OPD with left undescended testis, and you, in your clinical cursory gentle examination, by being friends with the child, you find that testis is in inguinal canal. Let's now make it very clear. Is it a retractile testis or is it an undescended testis? Let's do that first, because we will commit ourselves to something which is not required. So an examination of that kind would require your warm hands, a friendly atmosphere, parents close by talking, and even the father or the mother could help doing the same examination which you teach them, looking at, can this testis be milked down to the bottom of the scrotum, number one. Which means that if you can milk this testis from the inguinal canal all the way to the bottom of the scrotum, it could be a retractile testis with a very strong cremaster muscle on that side. This does not require a surgery. So a child could have a strong cremaster reflex, and retractile testis has sadly many times been operated. It's just to bring it and place it there. The cremaster muscle is pulling it. So you don't have to bring it to the governor. Compared to where you really find that this is an undescended testis. It has halted somewhere down there, and therefore we need to look into it. Obviously, the opposite side is down at the level of the base of the scrotum. So you need to look into. 3 years is quite some time. Normally, frankly speaking, as the RCTs and as Cochrane review talks about, things have changed dramatically. There was time when I was a student of Bailey and Love 27, 28 years ago, 30 years ago, things were different compared to what we look at. So the changes start happening very early, and you want this testis to be functional both from the exocrine and endocrine part. Therefore, you want to bring it as low down as possible, as early as possible. Referring it to your surgical colleagues is a good idea. You've done an ultrasound, you looked at this child. This child, if not a retractile testis and an undescended testis, has halted itself somewhere around. You could bring it down and bring it in a place where it's required. So first differentiate and let your surgical colleagues handle it. Go ahead.
And what about if we find a completely undescended testis in the neonatal period, bilaterally? So should we start investigating straight away, because there's a problem? It could be an ambiguous genitalia.
Absolutely. Absolutely. Perfect. Perfect.
So in this case, we should be investigating it straight away if it's bilaterally.
Bilateral undescended, we need to rule out for sure that this is not an ambiguous genitalia. This is not an intersex state. You will have to look into that. I mean, the best way is to look at a karyotyping straight away. Number one, the two testes which you see could either be testis or could be ovotestis too. So you got to look into that first. So that, as we always discuss, non-invasive to invasive, we get non-invasive. We look at a karyotype because it's a bilateral undescended testis. An ultrasound which shows that normal looking testis out there, so good enough. You've proven it's 46XY. Looked at the ultrasound showing two testes, both of them lying at the edge of the inguinal canal. It's all about bringing them down. And that's where a surgical colleague of ours will look into his expertise of doing it as a single stage or as 2-stage, depending completely on him. So for that aspect, I can look at that, and that authors review recent literature and came to conclusions, and I completely respect that. To me, the treatment of choice still is to bring the testis out whenever you pick it up beyond 6 months. So in today's learning, compared to what it was taught to us when I was a student, up to 1 year was a good waiting time. We don't wait beyond 6 months anymore. That means 6 months is a good waiting time. You have a child at 3 years. While you're going to attempt a therapy of that kind at 3 years, you will have to look at the possible long-term effect on spermatogenesis if you look at anything on the hormone side. If there's a surgical correction possible, the best and the possible way is to bring it down to a location where it can be clinically palpated by the mother as she bathes the child and looks at it around. To me, orchidopexy should be performed as early as beyond 6 to 12 months in almost everybody once you have picked up a disease. Because you hardly know, the changes which are happening are so gradual till one day the child comes to an edge. At that point in time, one of them may not be functional. But let me come back to you. There are people who have been adolescents and even adults who have come to us, to urologists across the world, who have got bilateral undescended testes. And these children are not who would be possibly becoming parents, but their endocrine function is still maintained. They're all sexually active. They've got the testosterone active. So maybe the endocrine function is something which is maintained. The exocrine function goes away completely. That's what it looks like. So the earlier you bring it down, you look at that. And then there's a host of other issues, including the risk of responsibility of malignancies, which you need to wake up to it.
Absolutely. So you would suggest orchiopexy to be done as early as possible, not to leave it too late. Okay, yeah, that's the point taken. So we shouldn't wait around at all. Now, if we are faced with a neonate like this, as I've shown in the picture, like we are in for a shock where we have seen a epispadias, obviously epispadic, and with the scrotum displaced downwards, with the penis, with the epispadic opening, everted bladder. So basically, it's a rare type of malformation. And just your thoughts on this, a few lines on this.
Yes, so the very few lines are, I see both pediatric and adolescent. That's what it is. This is an extrophy epispadias complex. That means your bladder is, the anterior bladder wall is missing. The penile shaft is not rolled into the two corporal bodies over a skin and over the corpus spongiosum of the urethra. The urethra is just underneath the bladder, which is dorsal rather than ventral. These patients would require, frankly, bilateral osteotomies at 6 weeks of time, number one, or maybe 3 months time, not to rush it on day of the surgery. Number one. Number two, we need to do an augmentation cystoplasty. We need to do a young D's bladder repair and a Cantwell Ransley. It all involves easy, good hours from breakfast to dinner, so that you do a good job on this child. Because sadly, the number of patients I see as adolescents are sad. They all come where this bladder has just been closed at birth. The penis has been just closed. And what you get in adolescents and when the baton is passed is about, you need to correct them because they're totally incontinent. The bladder has never grown. So you got to create a bladder out of it. So you want to give them an augmentation cystoplasty. You got to create a sphincter, which is called a young D's sphincter repair. And you've got to give them a corporoplasty by a Cantwell Ransley where you repair the epispadia. So bladder and epispadia is repaired together. These are challenging surgeries which I get to see, Dr. Sanjukta, in adolescence and even in adulthood. I've done at the ages of 25, 35 years.
What is the outcome like? What would be the outcome like in terms of continence, in terms of long-term sexual function? Is the results good, or once you have missed the boat in the early life, the results will not be as predicted?
So the results are good on one aspect. The kidneys are not damaged. So child lives a normal life, number one. Number two, as a child goes to adolescent and beyond, compares with others, and that's where comparison of the shaft comes in. The bladder is good enough. Many children who have been done early in their life, in that 1-2 years to 12 years kind of thing, learn to void by Valsalva's maneuver, which is all about compressing and pushing urine out. Many of them are actually taught, because you've done an augmentation and the mucus discharge is a part of the ileum or the sigmoid use. We do clean intermittent self-catheterization as a child grows up. As regards the shaft and the functionality and the capability of the organ created as external genital, patients do require a redo surgery if done early in life, because then you look at the Cody correction, you look at the straightening, you look at the lengthening. I'm involved in all these as a reconstructive urologist from adolescence to adulthood, and we look at, they almost always in a dragnet of few surgeries in their life. But it's not so sad as it was in yesterdecades, where our teachers taught us and took the subject to very high level. Subjects have changed. So we do augmentation cystoplasty. We get a great control by doing a young D's. I think we have got around 25 to 40 patients right now at all these aspects of different categories of complete epispadias to a complete extrophy epispadias to complete repair. And most of them have done extremely well. They have got a mild degree of stress incontinence, and that's where you are balancing between a continence and an incontinence. And then you want to err on the side of continence, where if you don't err on the side of continence, the child will not go to school. He'll be a wet child forever. So you want to let the bladder grow. So bladder grows only when the child holds urine. So that's a great balance you need to do. And there can be failures on this. Recorrections and surgeries for a lifetime till they grow and become functional as a part of this journey.
Okay, thank you very much. And now next one is one of the situations avoiding dysfunctions, where we have named a fancy name for Vincent's curtsy, which are the holding maneuvers. to prevent urinary leakage, usually more seen in females, but can be seen where there's a characteristic urge incontinence despite crossing the legs,
Yeah.
squatting, or doing what is known as the potty dance. The child usually wets before reaching the bathroom. So this is a kind of a avoiding dysfunction situation. So just your thoughts on that, because we do get to see a lot of dysfunctional voiding, and it's very frustrating because actually it's difficult to treat. The counseling part is difficult, the outcome is not that easy, and this abnormal holding behavior tends to persist. So your thoughts on that?
Yes, so pediatrician sees this. I agree that I personally have not seen more than one in my training days. I've not seen one in my clinical years recently, but I gather that this is a phenomena which has ingrained in a child's capability. And therefore, because of that urgency, which is refractory, the child has learned her own techniques. And that is a postural technique, which you named as potty dance or a Vincent curtsy. These children actually go through a trauma of their own kind, and they continue to wriggle around and create postures for themselves. And they wish they could tell parents in time, and then so the best way is to first go to the primary cause and look at dysfunctional voiding resulting from an overactive bladder. So you got to balance that, because this kind of a functional urological problem where a child is still learning but has learned an activity which is so gross becomes very difficult. So you did present a spin top urethra as one of them. Pelvic floor relaxation is another one of them. A lot of friendship and probably somebody lower in the Achillean of a busy pediatrician would help, talking and making the child and the mother understand again and again. And this actually helps. This is something which is sad, but then undoing is not easy, and therefore we need to continue undoing it.
Now, we get a lot of these, especially where antenatally diagnosed hydronephrosis. So, just a scenario where a male neonate born to healthy non-consanguineous parents, ultrasound parents done antenatally, ultrasound of the fetus done antenatally showed hydronephrosis. The child has no ambiguity of external genitalia at birth, no congenital anomaly, passes urine, good stream. And then what should be the management plan of this antenatal hydronephrosis?
Straight away. Yeah, perfect. That's great. So antenatal ultrasound, again, in observer-oriented investigation, could be a sonologist or could even be a gynecologist who has done that. There could be an evaluation around, and a lot goes by an anteroposterior diameter of the pelvis. A lot goes by that. And looking at how do you evaluate such a child? The child is still getting into the immunity status. So you do the first evaluation in the end of the first week, rightly said. And you could look at many of them actually getting down on their hydronephrosis already. If there was a comparison done antenatal in the third trimester, it's good to look at immediate postnatal evaluation. But if there is a hydronephrosis, look at is this a hydronephrosis or a hydroureteronephrosis? And that's where the large picture changes are. Is it a hydroureteronephrosis resulting from obstruction or a non-obstruction? That means, rightly pointed out on your right side, is it a VUR, which is already grade 5, grade 4? Or is it a PUV? Or is it an obstruction low down as a ureterocele? Or is it only hydronephrosis with a complete PUG obstruction? A lot goes on by the measuring the diameters, and a lot goes on by the third month MCU to know what, the MCU in the early days, but a third month nuclear imaging. So we look at that first to third month as a very important time to observe the changes happening. A lot by an ultrasound, where a good observer and the same observer measures that, is it 10 to 15 millimeters, where the chances of surgery will be much lesser and observation could help. Which a child could also be looked at the jets coming down into the bladder, compared to a 15 to 20 and a 20 to 30 millimeter diameter, when the progression happens and more of them deteriorate towards possible requirement for a surgery. So if you look at a PUG obstruction, the kidney is damaged much earlier compared to a primary obstructive megaureter, where the ureteric obstruction is low down. So there the damage may be much later. And therefore, it's very important to look at, okay, that's interesting. So whether you look at hydronephrosis resulting from a pelvic ureteric obstruction, or an obstruction low down in the ureter. So that's very important for us. If you have a PUG obstruction only, then you will have to wake up to it and probably go in with an early kind of a deciphery. That means you do a DTPA renal scintigraphy or EC scintigraphy and find that a complete gross occlusion. It's best to get in probably anything between 1 to 3 months later, do a minimal surgery. But if you have minimal doubts of hydroureteronephrosis, like the two pictures you picked up here, then you got to wake up to it. So if a patient has an antenatal hydronephrosis and you've gone and followed up, you will conclude it by a logical conclusion of whatever required. But out here, hydroureteronephrosis could be either obstructive or non-obstructive. You are pointing to two obstructive cases. On your left, it looks like upper moiety ureterocele, which is close to obstructive, and the intravesical part is showing a ballooning. Wonderful pictures. You picked them up from some wonderful teaching program, it looks like. So that is an obstructive ureterocele. The way is to de-roof. It's all about de-roofing and removing the obstruction straightforward. Compared to a primary obstructive mega ureter, which you are showing me right now on the right side, which actually very classically shows that, again, it's obstructed. And that's where you will do a ureteric tapering and a ureteroneocystostomy, or in simple language, ureteric reimplantation. So two different cases, but both are obstructed down. One because of ballooning and a ureterocele, de-roof, and the job is done. Leave a stent for a while. Other one, you do a taper and operate completely because that whole segment is gone. So these are obstructive hydronephrosis. If there's a non-obstructive hydronephrosis, there's a vesico-ureteric reflux, the picture is completely different. 2 years child, 2 years young, yeah, staining to void MCU. Okay, so that's the pelvic region. I can see the prostatic urethra massively ballooned. Is this child a case of posterior urethral valves?
Possibly.
Yes. So possibly this is the case of PUV, where the bladder and the prostatic urethra have all become one. So what you're showing me could possibly be a large bladder and a prostatic urethra all become effaced into one cavity. And because it's low down in the pelvis, it's all the way below the pubic symphysis down to below the sacral promontory level. And then you see a reflux going to the left side. I'm not sure about the right side there, but it's looking like there is an obstructive hydroureteronephrosis. It could be also a large diverticulum of the bladder up there, diverticular bladder up. And this whole thing could be a prostatic urethra also. This could be a very significant kind of stuff where we should go in and do a good fulguration of the valves. The MCU is amazing.
Completely your case. Completely your case.
Yes. So VUR. Okay. So this is something we can just touch base around. You've already written something, but vesico-ureteric reflux is something where we need to wake up to around. In today's therapy, when you get where you get something which is a lesser grade compared to a very high grade early in life, you want to look at both sterile and non-sterile reflux causing injury very silently to the kidney. A visible injury could be a febrile UTI, which is not a good idea, but a silent injury is also equally bad. And therefore, if you have these grade 4 and grade 5 refluxes, in my hands and many of my colleagues have failed the sting therapy or the injectable therapies. We go in, taper and reimplant and save the kidneys from future damage as a child grows. More so in female children with grade 4 and grade 5, where they don't want to be on prophylaxis. As compared to grade 1 and grade 2, where you watch them closely and keep on prophylaxis, the grade 3 is the one which could grade 2 go to grade 1 and grade 2, or could travel to grade 3 and grade 4 if there are confounding factors, like this child has a secondary VUR because of posterior urethral valves and there is a trabeculated bladder. So it depends on which grade are you looking forward to. Grade 4 and grade 5 don't wait too much. You're having both sterile and unsterile reflux. You're causing injuries. You do a DMSA scan, see the amount of scarring which scares you around. But these kidneys, which we can save every day when they come in around, we are always very late in such cases when they present around. And therefore, all wet children, all dysfunctional children need to be evaluated in the upper tracts. All febrile UTIs need to be evaluated with an MCU and not miss out these things because it's too late when we pick up very high grade cases. So chemoprophylaxis from the lower grade, watching them very closely, and the girls need to be looked at and very closely watch around. So chemoprophylaxis is all about looking at a prophylactic dose of an antibiotic, which could either be in today's world, the sulfamethoxazole is completely getting over. So trimethoprim is available today as 100 and 200 milligram tablets. Nitrofurantoin is available as a 50 and 100 milligram tablets. These are two good stuff to be looking at, preventing a breakthrough UTI of other aspects which need to be treated. For example, the VUR could be primarily obstructive or non-obstructive. A VUR could be developed as a result of a posterior urethral valve. Treat the posterior urethral valve while you're looking at grade 1 to 3 reflux being treated medically. If you have something which is not going down and he has got still febrile UTIs, you will go and correct it right away. You may attempt a sting therapy, but in my hands, it has been a failure. I'm sorry. We have not been doing much on that. We have been radical surgeons treating and curing and probably cutting for it. So looking at that aspect, when you look at the larger picture of VUR, you're assessing and balancing it. You're doing it almost being friends to these kind of patients and families for a long time. All those moderate and severe refluxes will only worsen with passing of time. If it's a girl child and you know that there'll be a pregnancy and pregnancy-related issues later on, it's nice to taper and improve around. If you're doing a chemoprophylaxis for a girl child towards puberty, watch them, follow them, and go beyond puberty and watch them. All breakthrough UTIs are dangerous because they are hitting the kidneys faster and more bigger. Therefore, all these severe refluxes almost will never resolve. Get into your surgical colleagues and correct them in time, because the time will never come second time. It's important to look at that in time.
What I find in the VURs with the where we do suggest surgery, there is an immediate non-acceptance of the situation, and this is a common thing that we come across because what cannot be visualized from outside, the parents do not take that on as something that needs surgery, so they do not see that as a problem. So a good counseling is very important, and the mild grade VURs which we find is non-compliance with therapy. Why do we need to take antibiotics for so long? It's going to be harmful, etc., etc. So yes, VUR is a common and recurring problem. And the next case we have of hematuria, where a 5-year-old boy with non-obstructive voiding symptoms tugs at the penile shaft towards emptying, and there is on urine routine examination there is hematuria, there is RBCs, and there is blood. So your suggestions, please.
So I think we just talked about it in the early part of our presentation, that hematuria or no hematuria, a child tugging at the penis of recent onset, to me is possibly a bladder stone unless proven otherwise. He already has a hematuria, it's already wake-up call. This also happens when we do an augmentation cystoplasty, the bladder stones do form. These are all bladder stones resulting from different metabolic activities. But the management is to look at the size of the stone, look at and probably treating them. So in today's world, the male child's urethra is a very precious urethra piece. We normally would like to go in for a quick job. If it doesn't look anything good, we do a PCCL, we do a percutaneous puncture, enter the bladder, wrap up the whole thing, leave a catheter, and probably remove the catheter a little later for the bladder hole to heal. That's one. Yes, so we will treat all these hematurias with a recurrent UTI.
Yeah, now coming to recurrent UTI with lower urinary tract symptoms, are there any obstructive or storage problems? How do we kind of investigate? Because when we do an ultrasound QB, we may or may not come up with anything. So should we go on and do a MCUG even in older children? Should we do DTPA? And should we do also consider a cystoscopy? What are the complicating factors? So
Wonderful. So nice. So this is important. This is important for every pediatrician, every urologist, every pediatric surgeon, for all of us. A child getting recurrent UTI will have delayed milestones, insidious growth. Everything is gone further because the whole mechanism of homeostasis is disturbed. The recurrent UTI is only a lower tract phenomena, or is it a febrile phenomenon? Very important for us. If it's only the discomfort part without febrile, don't forget still to do a good imaging. But let's look at the episode components. As I said, febrile or non-febrile, recurrent every week, every month, etc., etc. A good clinical examination, a lot of talking to the parents around understanding, again, the bowel issues and the urinary issues and the wetness and all that aspect. Plus, very important, you did some, just go to the last slide, please. That was something very interesting. No, just go back. Yes. So complicating factors, I need to talk about this. That's a great point that you have raised up. All those factors which could complicate a normal UTI. A child of 2 and 10 or 20 years should get a UTI which should not be because of anatomical and structural abnormality. So any anatomical or structural abnormality needs to be identified as a cause of recurrent UTI. Let's wake up to this. What? If a child has got a phimosis, if a child has got a stricture urethra, a child has got a posturethral valve, a child has got a neurogenic bladder, a child has got a bladder stone or a kidney stone, are complicating factors. They complicate a UTI towards a complicated UTI, which means happening in the background of anatomical or functional changes which don't let a UTI to be completely treated or recur back again and again. Therefore, you need to go to the cause. And the cause could be, as I said, an obstruction or a functional obstruction. So either it's a phimosis or stricture urethra or a PUV, or it's a functional obstruction where there is a dysfunctional voiding. And that needs to be looked into. Febrile UTI or no febrile UTI, an imaging investigation to tell us that there's no hydroureteral nephrosis. A UTI of a kind which can go up the ladder to the kidneys is more common in children than in adults, only because the very important intravesical ureters are still not developed. So all these UTIs can go to kidneys much more than what happens in the pregnant women around. Therefore, an MCU is a very important aspect to look at, the VUR component of it, the dysfunctional voiding of it. MCU is a must. So in ultrasound, you can't do uroflowmetry in every child, but the larger picture of that is it. You go to the next slide if you want to. You had to put something. So unified approach is obviously urine collection. A very small child, you may need a catheter to collect a proper midstream urine or a suprapubic aspiration, or a mother looking at that kind of a child behavior where it can happen. So that is a very important approach because that will help us towards antibiotics. Now again, antibiotics for cure and antibiotics for prophylaxis are a lot related to complicating factors where you will identify a VUR, identify other aspects which you want to rush through. And that's where if you have become friends with parents around, you actually get the compliance better. They comply to a therapy, which are long-term therapies too, till puberty in chemoprophylaxis, or a surgery if required, which you demand immediately. So unified approach is to look at a proper collection and a proper treatment. And you have mentioned about, okay, that's great. Identifying bowel and bladder dysfunction is important. So in children who get recurrent UTI, in children who are wet, and children who are constipated, to me, is possibly a situation of demystifying ourselves and waking up to a deranged exit mechanism or deranged emptying mechanism. And we need to look at all these emptying mechanisms, right? So bladder, obstruction, and constipation need to be looked into completely with the parents. That's great. That's a great slide. Thank you.
So,
yes. So identify and correct the causes that you can take it. Look at the algorithms and ease and identify bladder bowel dysfunction. And this could sometimes be very serious too. That's possible. Completely.
So basically, I think when we are looking at recurrent UTI and avoiding dysfunction, we cannot decide that this is something that will go away or correct itself with time. We have to identify and correct the causes and make sure that there is adherence to treatment.
Absolutely.
So that is very, very important. And as you said, I like that term. It's an exit dysfunction. So exit dysfunction existing for the bladder as well as for the bowel. Thank you for that. That's a very important statement.
Yeah.
And so your show here about this pediatric urology issues in an adult. So because these children will go on to become adolescents and young adults, and the problems they have faced in childhood will also exist sometimes if we haven't corrected it properly into adult life. So please, your take from here.
So that's great, actually. You know, every urologist or every surgeon has somewhere deep in his mind looked at his own and his teachers and his peers' complications and looked at what we could do earlier and what we have done late kind of story around. In a child who's growing gradually, there are changes happening as formative years grow around. And, you know, every pediatrician and pediatric surgeon hands over the baton to an adolescent and to an adult surgeon, which means he has done a good job, which has sustained the child, and then it comes to corrections. Rightly you said, in a case of an extrophy epispadias complex, where we do something, we have to redo as age changes because of expectations and requirements. The problem is in functional urology, Dr. Sanjukta, which you have labeled and gone so deep into today, is about those which are irreversible. If a child comes with fecal agenesis and we miss it out, and the child was only emptying what is overflow rather than what is actually to be emptied as a bladder and a bowel, bladder and emptying mechanism, then we have missed the boat. Therefore, identifying problems which a patient says is a lot ingrained in the history. We can pull out more in the history when we interrogate, more so as a policeman to somebody across the table, and we pick up those things. We are capable of, we have been taught and we have trained on that. So it is important for us to look at functional urology as a very important aspect of that. Number two, sadly, many of these surgeries may not be redone because the parents may run away, as you said, compliance. Surgeries may have their own failures because of the healing powers, and these sometimes may require a follow-up around. So we need to look into these people with an aspect which is very important. To me, hypospadias cripples come because there are no males and no man. There could be adolescent and adults. They're losing their complete morale on this. Urovesical dysfunction where kidneys are getting injured. Many of them come with silent renal failures. We will end up at transplantation. Incontinence is treatable when we look at the causes, whether it's total incontinence, urge incontinence, stress incontinence, etc. Stone disease, once a stone former, always a stone former, a metabolic activity which we need to wake up to and possibly help these patients out. So to me, I think the pediatric urology aspect, handing the baton to an adult urologist is something about we are all partners around. And to me, when I talk about this subject, which you have brought in so well in the limited time that we have, that we could not have gone beyond to a level. To me, you know, Elvis Presley never wanted to be a singer. He wanted to transform or change music. That means he was thinker beyond times. Similarly, we all have Elvis Presley within us. We are mini Elvis Presley. We should bring it out. We should look at being a better interrogator, a better person who examines, spends more time with relatives, patients, and talking and being friends with patients, because children don't complain. They live with it. Parents do complain, but they have got so many things they miss out. When they come, it's too late. So if you have a mini Elvis Presley within you, please bring it out. It's that you could probably pick up cases much earlier, much better. You could counsel them better, and your pediatric surgery colleagues and urology colleagues would do wonders to many of these which can be treated around.
I think as a pediatrician, I would put in a comment over here is that I take every opportunity at vaccination, during vaccination, to examine the child from top to toe, including the genitalia, and ask about bladder and bowel, even in older children. And it's very important that, like today, I saw a child of Fallow's tetralogy, and I had been seeing this child for last 4 years, and the child is now 7 years old. But the mother had never talked about nocturnal enuresis. She said this child had so many problems, had brain abscess, Fallow's tetralogy. So nocturnal enuresis didn't seem a problem to her at that time. So I think we sometimes lose focus and think that some problems are small, but they loom large when the child grows big. Now, we have a couple of, we have until about 10 minutes to take a few questions, and got some interesting questions. One question from Dr. Jyoti Chavan, who has asked about significant urine infection at 13 days of age, needs evaluation, kindly comment. And I think absolutely, as a pediatrician, and if you go into the NICE guidelines or any other guidelines for the matter, urine infection at 13 days of age, you have to investigate fully. You have to do the MCUG, the DMSA, DTPA, all of it. But of course, you have to treat it first, because urine infection at 13 days of age, even if the child is responsive to oral antibiotics, you will give IV, and that's it, because you can you can cause renal scarring without meaning to. So oral antibiotics have limited role in UTI in a neonate. They should be given IV antibiotics. You should wait a month before you do the MCUG, and then you go on to do a DMSA DTPA. More than likely you will have an anatomical problem, and that's very important to diagnose and treat. Absolutely. And the next question, I think, Dr. Pandey, is from one of my surgical colleagues, Dr. Shanghamitra Bhattacharya, and she has said that I think we should get an ultrasound of KOB routinely in child presenting with hypospadias. Your comments on that? And how can it be derotated in the ER? I mean, she probably meant the torsion testis. So 2 questions from her: ultrasound KOB routinely in a child with hypospadias, and derotation in ER of.
Yeah, good one. So I wish I could have done justice to that by a demonstration, but to start with, number one, a child with a hypospadias alone, which could be granular, mid-penile, and penoscrotal, may really not require an ultrasound, because we are missing a focus a little bit out there. You have examined the child, you found the 2 testes down in the scrotum already, which are not retratile or undescended testes. There's no big reason for you to worry that there's an outlet obstruction for which an ultrasound will give you anything important. Incidentally, if you find something, you could be looking at that angle around, but a child with a hypospadias at the age of 2 years or 12 years or 24 years may not have an obstruction to the flow of urine, though the urinary opening may be a little smaller, but if you look at the flow patterns, they don't have any trouble. What they have is a grotesque looking shaft, they have a hooded prepuce, they have a glans which is bifid, etc. The urethral plate open. Does not behove that an ultrasound will do great things to it, but as a part of routine workup, which every pediatrician does it around an ultrasound abdomen and pelvis, there's no harm in doing it. But we are looking at a patient coming with one issue. We're looking at a focus investigation. Our investigation is to look at, this child has got viral testis down. He's a young child, not complaining of anything. The mother says voids well, but the stream goes haywire because of the kind of organ that he has got. You look at that. I mean, obviously, ultrasound you will do here to look at, has child got other aspects to it? If the child is constipated, number one, will have issues. If the residual volumes are good or bad, etc., etc. So that's one aspect. Coming to the derotation.
You wouldn't routinely recommend it. You wouldn't routinely recommend it.
No, absolutely no, because then I'll be missing the boat, and I'll be looking at the child came for hypospadias. I'm busy picking up the thick wall bladder or bladder thickness, which has got no meaning for some reason of the child around. You will look at a uroflowmetry later on when you create a urethra. So routinely may not, but then if there are things which are in the history, you would go ahead and work up all that because you're doing a non-invasive to invasive. Coming to the derotation aspect, I wish all those male pediatricians who are actually going to watch this, it's all about rotating. The rotation happens in a direction, which if you can open up one of the books, they will show you the direction of the cremasteric fibers. The direction is just opposite to it. What we do derotation out here for adolescents and adults is we take them to the ultrasound room immediately or get an ultrasound Doppler ready, and the blood supply is not there, we derotate it. The derotation is holding the testis in very early hours and not late hours. In the late hours, because of venous edema and the scrotal edema, you can't hold the testis, the child won't allow you. By the time there is edema and pain developing as a result of it. But in the early days, you can actually rotate it. So the left is rotated clockwise and the right is rotated anti-clockwise. But that is completely a practice. It's all about knowing that the cremasteric muscles come medial to lateral like that, and they're all fanning out like that. You have to turn it around because the cremasteric muscle has rotated it at least 270 degrees, or maybe more than that, or maybe 2 twists. So that amount of twisting, derotation alone may not work. Derotation, what we do under ultrasound Doppler is a way towards moving to the operating room. That means if somebody has got it 2 hours earlier or 4 hours earlier, if you can derotate and watch that the blood flows come back, you won't send him home. You'll take him to the OR right now and do a bilateral oculopexy. It's sadly we do 1 in 100 cases. Most of them come too late, and we do all those jigsaw maneuvers on the table and still land up with orchiectomy on one side and oculopexy on the opposite side. So it's derotation. Derotation may not balance too much. So derotation under the ultrasound activity, and you derotate and keep watching the blood supply. It can be magic in front of your eyes. You can create a magic. If it is very early hours, if it's too late, sorry about that.
Yeah, sounds extremely easy to do if it's early, but obviously it's needs a lot of practice. I'm sure it needs a lot of practice. Another quick question is from Dr. Dibyendu Rai Chaudhary. To review, the voiding diary is the most important initial step in managing this type of case. I'm sure he is meaning the enuresis. Voiding diary pro forma should be available in local language, and the party should be taught the way of maintaining the diary with patients. We couldn't agree with you more, absolutely, because yeah, unless it is in the local language, it's not
impossible.
Very for many people. And I think the same in the same vein, Dr. Nana Joshi has commented on our initial cases on PNE that please elaborate on pharmacotherapy with visual. Well, we couldn't do it, of course, in this kind of talk, because then that would have taken up the entire 1 hour or more. So maybe when Dr. Pandey thinks of postponing a surgery once again, we could do something completely on bedwetting. And because if we want to do justice to bedwetting or nocturnal enuresis, we actually need an hour or more even to come in with all the visuals, all the pharmacotherapy, all the evidence for and against. So I think today's talk was not meant for that alone. So we didn't go into the details of pharmacotherapy, but we could do it at another point in time. So these are the questions I've got so far, and I think it was an excellent session. And we are right. We have covered a whole gamut of pediatric urological problems. You've answered a lot of questions that I had, created some more, and I'm sure I would be knocking at Dr. Pandey's door ever so often again to get some input of his for treating my patients. And he has been so kind in the past, and I'm sure he'll be kind in the future as well. Uroflowmetry still remains a gray area for us because we kind of have a brain block regarding that. I think we could do a session on that as well, because I think it's more of a brain block than anything else. It's not as difficult as it seems to be, but we do avoid it because we know so little of it. Dr. Pandey, last few words before we close today's session.
Yeah, Dr. Sanjukta, I was soaked in the glory of the entire A to Z cases you put in around, which were very practical, which were a part of your daily folklore and which every pediatrician goes through. Everybody in the audience who does urinary tract issues is a urologist. So you shape up yourself into multiple aspects, and each of you do urology to the bit that you would do. And therefore, it's called teamwork. And teamwork is the only way where we can actually take up this stigma of I cannot do, we can do better. That's how we work around in Kokilaben Hospital, where we have a wonderful team of pediatricians, pediatric surgeons, urologists, nephrologists, and that happens in every hospital city and every 2-tier city where colleagues who do work around. I also gather that the kind of request which could be coming around in terms of being very actual into treatments of these cases could not have been taken forward because we are looking at a whole series around. But as I rightly said, we would always be keen to take one subject forward over an hour and look at X number of cases, and each case could be broken up into secondary, monosymptomatic, non-monosymptomatic, and take those cases. They all have done very well in our hands, so why not in your hands? You always happen to be partners. We all work in different spheres, but I gather that we can be in touch all the time. And I just saw Dr. Sanjukta put in the email addresses for various aspects that you can connect around. I also push myself too much on the Twitter, looking at keeping myself awake and active. And we look forward to these kind of teamwork. Dr. Sanjukta, thank you so much. Sipla, thank you so much. It was amazing to have thought about this. This also put forward a possibility of future possibilities of waking up to newer subjects, and maybe, who knows, uroflowmetry, urodynamics, and other pediatric issues, or maybe one issue covering A to Z on that. Thank you again, and have a great evening for all of you.
Thank you very much for your time, and wrapping up for today. Thank you, Sipla, and good night, everybody, and thanks for watching.
Thank you.